Welcome everyone. Thanks for joining us for today's webinar on the impacts of COVID-19 and new treatment approaches. This webinar is presented by ADCES in association with AstraZeneca U.S. Medical Affairs, Cardiovascular and Metabolic Diseases Division. This webinar is educational in nature and contains no promotional or product information. There is no continuing education credit for this webinar and handouts are not being distributed. If you would like to ask a question during the presentation, please feel free to type your question into the Q&A box on your screen at any time, and we'll answer as many questions as we can during the Q&A session at the end. So I'd like to introduce our presenters for today. Rochelle Richner is a family nurse practitioner currently working with AstraZeneca Pharmaceuticals as a Director of Medical Alignment. Her role is centered around supporting initiatives across the cardiovascular and metabolic therapeutic areas within the headquartered medical affairs team. And Julia Blanchette is a registered nurse, certified diabetes care and education specialist, and has her PhD in nursing science. She's currently a postdoctoral research fellow in integrated diabetes management at the University of Utah. We're very excited to have them both here with us, so I'll turn it over to Rochelle to get us started.
Thank you so much, Megan. I appreciate that kind introduction, and also want to thank Julia for being on the line for this presentation today to give the audience and the members of ADCES some clinical pearls and some key takeaways that they can apply. First, going over the learning objectives, I'm just going to do a brief overview about the basics of COVID-19 and understanding that this is a rapidly changing environment almost by the day and even the hour, so it seems. Also discuss the national and global impact of COVID-19. Also touch on some of the high-risk groups for COVID-19, as well as discuss the risk mitigation strategies for individuals. And finally, we'll discuss new treatment methods, vaccine development, as well as guideline recommended therapy. I just want to start off by giving a brief overview of what we know to be true about SARS-CoV-2 or coronavirus. It was indicated in late December of 2019 that the Chinese CDC was informed about a pneumonia of unknown etiology in Wuhan, China. And as you can see, kind of tracing around this timeline from late December 2019 and tracking all the way through January and February of 2020, the Chinese authorities really activated a level 2 emergency and identified this as an epidemic. And shortly after, in the month of January 2020, the structure of SARS-CoV-2 was sequenced, and it was determined that it shared an identity with other SARS-like coronaviruses indicative of animal-derived origins. And it wasn't by the end of January that this was considered an international emergency, and a public health emergency of international concern by the WHO was declared. And taking that, pushing it forward into February of 2020, seeing that over 80,000 people had been impacted from over 40 countries. And in understanding, the SARS-CoV-2 and how it causes COVID-19 disease, what we can see here depicted on this slide is that the coronavirus really kind of falls within its own family of viruses that are found in a variety of both animals and humans. And when we talk about, corona is really part of the name and also derived from the actual structure of a crown-like appearance for these S or spike proteins, which have really been a high topic of conversation as the virus is differentiated. And it is the protein that is a target for a lot of the monoclonal antibodies and vaccines that I'll be describing later on in the discussion. And just to provide some context related to prior coronaviruses that were endemic in humans, I just want to point out that the first coronavirus was discovered in humans in the 1960s. And these viruses have really been responsible for many mild upper and lower respiratory infections in both adults and children. some of the more notable coronaviruses that we may be aware of, have stemmed, in the range of 2002 to 2003 with coronavirus that was responsible for that endemic. And in 2012, the MERS COVID virus, so the Middle Eastern Respiratory Syndrome virus that was responsible for that endemic. And then finally bringing us up to date to the SARS-CoV-2 or coronavirus that we are currently seeing today. What I'd like to do now is just briefly describe, the viral entry into the host cell. And the SARS-CoV-2 really targets the respiratory tract epithelial cells by way of this spike protein. And it's really important to, classify this spike protein in its relationship with the ACE2 receptor, so the angiotensin converting enzyme 2 receptor. It is by way of this attachment that we then see the shifts of the viral and host membranes fusing, and ultimately that viral entry into the host cell. And after we see the viral entry into the host cell, we see all of the signs and symptoms that go along with an infected person with COVID-19. That viral entry is very dependent of that spike protein and then enveloping that protein into the ACE2 in the host cell surface. And we see the viral endocytosis then happen. And some of the symptoms observed in many of the COVID-19 patients may range from the digestive system, the heart, the kidneys, the respiratory system. And it's also been hypothesized that SARS-CoV-2 may also invade the central nervous system via the peripheral neurons, suggesting that there is an interplay in the interneuronal transfer of SARS-CoV-2. And it's at this juncture that I want to welcome Julia in to give a clinical pearl to our audience.
Thank you, Rochelle. So just really quickly, I'm going to touch on here. So as we're talking about how SARS-CoV-2 affects multiple organ systems, it's a good time to point out that for people living with diabetes, they may already have comorbidities or complications, particularly cardiovascular or renal complications. So the stress of COVID on those systems can cause additional complications and put those people with diabetes at even higher risk of detrimental COVID outcomes.
Thank you so much, Julia. I really appreciate that. And as we move into describing some more of the signs and symptoms surrounding COVID-19, what's really laid out here for you to observe is some of the most common symptoms that we might already be well aware of, as well as some of the less common symptoms such as that loss of taste and smell, sore throat, headache, diarrhea, conjunctivitis, as well as some of the more serious symptoms such as dyspnea or shortness of breath, the chest pain or pressure, as well as that loss of speech for movement seen in those more serious cases. And I would also like to point out some of the manifestations that are associated with severe disease. ARDS, acute respiratory distress syndrome, cardiac dysfunction, certain inflammatory conditions can really be exacerbated by COVID-19. Neurological dysfunction, so there have been reports of thrombotic complications, both hepatic and or renal dysfunction, as well as the exacerbation of other underlying comorbidities. And Julia, if you wouldn't mind just sharing another clinical pearl for our audience as well around COVID-19.
Yeah, so for people with diabetes, it's really important to look out for other symptoms that may be specific to diabetes when presenting with COVID-19. So people who have type 1 diabetes are at particularly high risk for ketones and hyperglycemia during this time. And then those with type 2 are also presenting quite frequently with ketones and then also with hyperglycemia, like with any illness. So it's really important to, talk to your patients to make sure that they have ketone checking supplies available, regardless of if they have type 1 or type 2 diabetes. And then to instruct them to monitor ketone levels and assess if they have high ketone levels and additional medical help is needed at this time, because we are seeing a lot of people with diabetes, even type 2, present in DKA with COVID.
Great, thank you, Julia. I appreciate that, and really that tie between specific the diabetes patient. We'll highlight some of the other high-risk patient groups, but diabetes being in that cohort as well. In terms of transmission of the virus, again, this is kind of a review to what we already know to be true about the virus to date. Those face-to-face, those close interactions where droplets or aerosolized particles can be transferred from an infected person to another. Some other considerations to exposure are, some key takeaways here is that patients are really most infectious during those 2 days prior to symptom onset, and they may remain infectious up to 14 days or longer, and this really is kind of been more of an average, but can vary from patient to patient. Something else to keep top of mind is that prolonged exposure to asymptomatic individuals. That's why the distancing is recommended, as well as no greater than 15 minutes. And even some of that brief exposure to symptomatic individuals has been associated with a high transmission risk of infection. Even though brief exposures may be less likely to result in a transmission, it is something to keep top of mind. I want to just switch gears and talk about the diagnostic testing for COVID-19, as this has evolved really since the discovery of the virus, and is used really as that gold standard to diagnose patients with acute infection, as well as those hospitalized patients. And what you'll see listed out here are some of the panel testing recommendations, both in the acute setting as well as the hospitalized setting, as well as recommendations around retesting. So PCR testing, using that upper respiratory tract sample, this can be a nasopharyngeal, nasal, or an oropharyngeal specimen. And serological testing for diagnosis of determining immunity to COVID-19 is not recommended. As for the intubated patients, it's recommended to obtain a lower respiratory tract sample to establish a diagnosis if that initial upper tract sample had been negative initially. In terms of retesting, it's not recommended within 90 days of a previous COVID-19 infection, or even following a significant exposure, as this could potentially create a false positive in those patients. It's also, recommended to consider testing in patients who present with symptoms in the absence of any other alternative diagnoses. We'll just kind of go through the impact of COVID-19, what this looks like in terms of cases in the United States, but also examine what that looks like from a global perspective. And mind you, this is data that is current as of April 5th, but as you can imagine, these numbers are ever growing, and we can kind of see the disease patterns fluctuate over the lay of the land here in the United States, currently having over 30 million cases, see the rise in cases over the last 7 days, as well as the death count as well. We transition to looking at these cases globally. You can see the substantial global impact of COVID-19 in the U.S. and all around the world, with over 130 million confirmed cases and over 2.8 million deaths to date. As we begin to discuss high-risk patient groups, this is the most recent chart that was released by the CDC just last week, of patients in any age with some of the conditions listed here that may be at a risk for severe illness from COVID-19. I do just want to call out that originally, when this list was populated, that type 2 diabetes was the only one that was considered high risk, but type 1 has now been added to that high risk list. Other conditions, from cancer to chronic kidney disease, chronic lung disease, neurological conditions such as dementia, Down syndrome, heart conditions, anyone really in an immune-compromised state. Liver disease, obesity has still kind of made its way into this list of high-risk groups. Pregnancy, sickle cell disease, or thalassemia, smoking, and that includes patients who were also former smokers as well as current smokers, as well as stroke or cerebrovascular disease, and those patients with substance use disorders. And highlighting the cardiovascular complications of COVID-19, what we can see here is that sometimes cardiovascular comorbidities are very common in many of these inflammatory states, and especially in COVID-19, these may increase the risk for morbidity and mortality in patients with COVID-19. And of the cardiac complications, understanding myocardial injury or myocarditis, we see that incidence rate among COVID-19 patients hanging between 7 and 17%. Acute myocardial infarction, approximately 9%. Heart failure and cardiomyopathy occurring in between 23 and 33% of patients presenting with COVID-19. Arrhythmias, about 17%. Venous thrombotic events, between 3 and 4%, as well as stroke, just under 2%. And I want to also stop at this juncture and ask Julia to provide the audience another clinical pearl for cardiovascular complications with COVID-19.
Yeah, so I really just wanted to use this time to highlight that people with diabetes are already at higher risk for cardiovascular disease and comorbidities. So contracting COVID-19 can really put them at a lower threshold for these cardiovascular events to occur. So, if someone with diabetes, if you're working with someone with diabetes and they ask if they should get the vaccine, I'm just putting this plug in here that it really protects them not only from contracting COVID-19, but it really can also protect them from the complications cardiovascular-wise that may present with COVID-19 as well.
Great, thank you, Julia. And now we're going to kind of get into the bulk of the presentation as it pertains to current treatments for COVID-19. We'll talk about some of what is currently recommended in terms of antivirals, as well as monoclonal antibodies, and then close out by talking more to what is going on with vaccine development and discuss the differences in many of the vaccines that are currently available. In terms of risk mitigation measures, this is, again, currently what we know to be true in terms of reducing the spread of the virus from person to person. So the scrupulous hand washing, disinfecting those high-touch surfaces, wearing a mask, if you're sick or having signs and symptoms, or if you're advised to. Practicing social distancing and self-isolating if you may have an exposure or if you are actively ill with COVID-19. Throwing tissues away, being very mindful of coughing into, the tissues or the elbows and disposing of those right away, as well as avoiding non-essential travel and international travel. And I understand that, the guidance is probably going to change around that, again, as this is an evolving situation that we find ourselves in. If you can go to the next slide, evolution of treatment options. You're good. So in terms of the evolving treatment options for COVID-19, we see in terms of medications that have been repurposed, as well as monoclonal antibodies that have been studied, and finally, the vaccines, which have been a pretty hot topic, especially in recent months. When it comes to repurposed medications, we've seen remdesivir as well as corticosteroids, as well as baricitinib and remdesivir being explored for the treatment of COVID-19. More data is needed in terms of ivermectin, as well as the interleukin inhibitors and interferons. And then, as you can see on the right-hand side of the slide, medications that are not currently recommended outside of the setting of a clinical trial, those being hydroxychloroquine, lopinavir, JAK inhibitors, TK inhibitors, IVIG, as well as anti-interleukin-6 monoclonal antibodies. And what you may see in the literature more so around the IL-6 antibodies is IL-6 is very overly expressed in circulation and really potentiates what we call kind of that cytokine storm. So you may see a lot of data surrounding IL-6. For the monoclonal antibodies that are currently approved for emergency use authorization, bamlanivimab, carfilzomib, imdevimab, and the combination of bamlanivimab and atezolizumab together, as well as there are several that are currently under investigation for use in patients. In terms of vaccine development, what we know to be true is that currently emergency use authorization covers the Pfizer vaccine, the Moderna vaccine, as well as Janssen's vaccine. The AstraZeneca vaccine is pending emergency use authorization here in the United States, but is approved for the European Medical Association. And there are many other vaccines that are currently under investigation and development that I'll share at the end of the presentation. You can go to the next slide. You're good. So in terms of antivirals for the treatment of COVID-19, this slide really describes the approval of remdesivir as it was the first FDA-approved treatment for COVID-19. And its efficacy has been supported by several randomized controlled trials. And this slide really depicts the mechanism of action of remdesivir. So it directly inhibits that replication, that RNA replication that is so vital for a virus to really thrive. Remdesivir should only be administered in a hospital or healthcare setting that is capable of providing acute care comparable to inpatient hospital care. And some of the most common side effects include increased LFTs and other allergic reactions have been seen. Next slide. All good. For monoclonal antibodies, again, I alluded to on the previous slides, they have either been approved or granted that emergency use authorization by the FDA for the treatment of COVID-19. Bamlanivimab and atezolizumab are neutralizing monoclonal antibodies that bind to different but overlapping epitopes at the receptor binding domain. So trying to really mimic what our own body would do in the setting of an infection, but also not giving the virus that opportunity to get to the receptor, have the fusion, and have the viral entry into the host cell. As well as carfilzomib and imdevimab are recombinant human monoclonal antibodies. They bind to the non-overlapping epitopes of the spike protein at that receptor binding domain, and they'll really, again, block that binding so that viral entry into the host cell cannot take place. Next slide. Okay. Again, with the monoclonal antibodies, what you can see here is some of the data that has been seen in randomized controlled trials with bamlanivimab and in combination with atezolizumab as well as carfilzomib and imdevimab. And seeing these efficacy outcomes as either greater reduction in the viral load, more favorable pulmonary categories that are, sustained recovery time, significant reduction in the proportion of patients who had COVID-19 related hospitalization or death from any cause, as well as a greater reduction in the nasopharyngeal viral load. These are some of the common primary efficacy outcomes that have been examined with the monoclonal antibodies that have been studied to date. And again, more are being investigated, so stay tuned. Next slide. All set. As far as immune modulators for the treatment of COVID-19, what I do want to discuss briefly at a very high level are the Janus kinase inhibitors, particularly baricitinib, that was studied, and its recommendation for use is in conjunction with remdesivir in hospitalized and non-intubated patients who are requiring oxygen supplementation. And as you can see, the mechanism of action laid out there, what you're seeing with a JAK inhibitor is that interference and disrupting that signal transducer that gets these proteins involved for vital cellular functions, so including those cell signaling, the growth, and the survival. So having an impact on the virus as well as the spread of infection. And some of the data that is surrounded baricitinib is for the ACT-2 trial, looking at these double-blind randomized controlled trials versus placebo, for up to 14 days or hospital discharge. And the population studied, again, is those patients that are hospitalized with moderate to severe COVID-19, looking at a primary endpoint for that time to recovery and seeing that significant impact on time to recovery being shorter in patients who were treated with baricitinib versus placebo. If you could go to the next slide, please. All set. So, as we alluded to, some of the available treatments as well as others that may be under investigation that I haven't already listed out. What you'll see here is a collection of various treatments that are under early investigation. Anakinra, an interleukin-1 receptor antagonist. So what this is doing is essentially blocking that activity of these pro-inflammatory cytokines. Colchicine, really exhibiting that broad anti-inflammatory as well as immunomodulatory properties. So this reduces kind of that chemostasis, the phagocytosis, and actually also mitigates neutrophils in the setting of an infection. Interferons, really modulating an immune response in a very specific, but not maybe all viral infections. And they really bind to the interferon alpha and the beta receptors on the cell membrane, and that has been helpful in the immunomodulatory effects that need to be seen. Intravenous immune globulin, or IVIG, again, kind of derived from that pooled plasma and contains antibodies that are typically found in human blood and are currently under investigation. Ruxolitinib, this is another JAK inhibitor or Janus kinase inhibitor that really mediates that cytokine release as well as that endocytosis. Statins, the statins have anti-inflammatory properties. They may allow for some sort of protection in the setting of infection. Vitamin D, kind of looking at these pro-hormones as an active form of vitamin D, this could potentially bind to the target tissues and pathways that increase the absorption of calcium and phosphorus, and you're reducing parathyroid hormone synthesis at that level. Again, the data on this has yet to fully come to fruition, but something to keep top of mind when it comes to other potential COVID-19 treatments. If you can go to the next slide, please. Yep, all good. Okay. So in terms of the pharmacologic management of patients with COVID-19, what you'll see here on this slide is panel recommendations as it pertains to disease severity and what is recommended in terms of treating, both from the non-hospitalized patient, mild to moderate disease, hospitalized but not requiring oxygen, hospitalized but require some supplemental oxygen, maybe through regular nasal cannula, but doesn't require high flow nasal cannula or anything of the sort, as well as hospitalized patients that require oxygen delivery through high flow nasal cannula, and those very ill patients that may find themselves on mechanical ventilation or ECMO. And really the summary of the data is really against the use of corticosteroids within these patients with mild to moderate disease in hospitalized patients that aren't necessarily requiring supplemental oxygen. The use of corticosteroids as well as the utilization of remdesivir are really for those hospitalized patients or those patients who are seen in more of a severe state and are able to be treated, and they have that access to resuscitation and advanced levels of care. And I just want to stop here to invite Julia back to give an additional clinical pearl to our audience.
Yeah, thank you. So here I'm going to kind of just bring in a quick discussion about keeping in mind that when managing a patient with COVID-19, whether it be outpatient or inpatient, their insulin requirements are likely going to be increased just due to that inflammatory response with COVID-19. But particularly for those who are inpatient, who are requiring oxygen or mechanical ventilation, who are, based on these guidelines, likely going to be placed on corticosteroids, their insulin requirements will significantly increase from those corticosteroid doses as well. So even those that may not have been on insulin previously may require insulin in those cases. So just to keep that in mind.
Thank you, Julia. I appreciate that.
And I'll go to the next slide for you.
Great. I appreciate that as well. So in terms of vaccine development, what I'll highlight through this section is the COVID-19 vaccines that are currently available here in the United States, as well as highlight on one in Europe as well. I want to also take this time to go through some of the differences between mRNA vaccines as well as viral vector vaccines, and just highlight on some of the vaccination rates that have been seen here in the United States. If you go to the next slide.
Sorry, I think I advanced it a little quickly here. We're on the COVID-19 vaccine slide.
Okay, excellent. So what you can see depicted on this chart are really the four mainstream vaccines that have been seen typically here in the news, both the Pfizer and Moderna vaccines being our mRNA vaccines, and the Johnson & Johnson vaccine and the AstraZeneca vaccine being non-replicating viral vector vaccines. What is also included is the efficacy seen across the clinical development trials for each of these vaccines, as well as the dosing. These two dose schedules really giving that primer and the booster, whether it be 21 days apart with Pfizer, 28 days apart with Moderna, or the AstraZeneca vaccine, 4 weeks apart for that, all administered intramuscular. And you can see the variation among what is recommended in terms of storage and the indications. So all except for the Pfizer vaccine are indicated in individuals 18 years of age or older. The Pfizer vaccine is indicated in patients 16 years of age or older. There are ongoing studies in terms of younger patients and adolescents in vaccine development, so stay tuned as more data will eventually come our way. In terms of approval status, you can see the FDA and emergency use authorization for Pfizer, Moderna, as well as Johnson & Johnson. AstraZeneca is currently approved by the European Medicines Association and pending emergency use authorization here in the United States. We can jump to the next slide. All set? Great. So what I just want to highlight here is some of the differences between messenger RNA and viral vector vaccinations. There are advantages and limitations to both. But in terms of viral vector vaccinations, what is used here is a modified version of a virus. And what happens is that a sequence of DNA really encodes the instructions for the body to make the spike protein, or the S protein, which is typically found, as we had said earlier on in the presentation, on the surface of the virus. So after it's injected and you start to see that replication of that protein, it's triggering the body to release into the host system, triggers that immune response by binding to antigen-presenting cells of the immune system. And some of the advantages of that viral vaccination do include you're showing a highly specific gene delivery to the host cell with a vigorous immune response. That's why you see that effectiveness of the vaccine. It also avoids that handling of any infectious particle, and has also been used widely for the Middle Eastern respiratory, or the MERS-CoV, with positive results from those clinical trials. Some of the limitations to viral vector vaccines include the host may possess immunity against that vector if they have had a prior exposure, and could potentially reduce the efficacy there. And there has been very small reports that these may lead to cancer due to kind of that integration of the viral genome into the host genome. And contrasting the viral vector vaccines into the mRNA vaccines, what is seen in the setting of an mRNA vaccine is that encapsulated of a fragment of mRNA sequence within a lipid nanoparticle. It's really including the instructions to make a spike protein or S protein, again, that is found on the coronavirus, and it enters the host cell and uses the cell to kind of replicate that protein, and then the immune response is then triggered. Some of the advantages of mRNA vaccines include that the translation of mRNA occurs in the cytosol of the host cell. So it averts any risk of any sort of integration into the host genome that could be potentially seen in a viral vector setting. However, some of the limitations of mRNA vaccines have included safety issues with reactogenicity. They have been reported with various RNA vaccines. No vaccine is without side effects, and it can also have a possibility for instability if it is not administered, stored appropriately, etc. If you could go to the next slide. What we'll do as we start to round out the end of the presentation is talk about what does the landscape look like for vaccines here in the United States. Having 3 emergency use authorization vaccines available to the public, and see over 200 million doses delivered. And you can see the breakdown and the number of patients who are fully vaccinated by the vaccine type as listed out there, as well as some of the age ranges. You see our younger folks, 18 years of age or older, either partially vaccinated with at least 1 dose, and nearly 60 million Americans fully vaccinated at this point of time. Again, this is data that was just pulled earlier this week. And what I'd like to do now is invite Julia back to really give us one last clinical pearl before we move into our summary. But we'll go to our next slide, because I do want you all to be very well aware that there are ongoing vaccine studies, and we can see the sponsors, the vaccine type, as well as which phase of clinical trials these are in.
Awesome. Is that your last slide?
Yep.
All right. So I will talk a little bit about working with patients with diabetes here. So I don't actually have a slide, so we're going to leave up the ongoing vaccine study slide. But I wanted to talk to you guys because, we have all of this data on vaccines and how they work, and that they do work, and they protect people who are at high risk from getting COVID and then the associated complications of COVID. But, based on a recent Kaiser Family Foundation report, about over a quarter of the American public in general is vaccine hesitant, including about 22% of people who either have chronic conditions or live with someone with a chronic condition, such as diabetes. So, the most common groups to be vaccine hesitant are the age group of like the 30 to 49-year-olds, those of Black race, and then those who live in rural areas. And over 1/3 of these populations report vaccine hesitancy still. So people are vaccine hesitant for a multitude of reasons, but particularly the people of minority, ethnic, and racial groups that are vaccine hesitant are vaccine hesitant due to what we've created within our own medical system. We have systemic racism due to previous mistreatment and experimentation with medical procedures with these groups. So that's led to a long-term mistrust with vaccines and other medical procedures. So it's really important that you work with people who may be vaccine hesitant, particularly in these groups, and support them in their decisions, build trust with them, and really give them facts about the vaccine, and really don't judge them and acknowledge and validate their concerns. So some other reasons for vaccine hesitancy are related to some misinformation. A lot of that is floating around on social media. So you guys may hear stories that come out. So there'll be a news story that someone has died or had some type of extreme medical event shortly after receiving a vaccine, and then these stories will be linked to the vaccine even before a full medical investigation takes place. So it's just important when people bring this up to you as a concern, just to tell them that these are like one-off instances a lot of the times, and that it may not even be related to the actual medical evidence, and that there's, people have other comorbidities that can also lead to medical events, and they could just be happening at bad times in relation to the vaccine. But bottom line is a lot of people with diabetes you work with may be vaccine hesitant, but over 85% of people trust their healthcare providers with vaccine information. So it's really important just to acknowledge all of those concerns they may have, not judge them, and really provide them with facts and science, and really build trust with them. So that's all I have.
Thank you so much, Julia. I really appreciate you inserting some of these clinical pearls throughout this discussion. I think it's helpful for those who are interfacing with patients every day to kind of have a couple more takeaways after the remainder of this presentation. And with that, I will hand it over to Megan. We can answer some Q&A.
Great. Thank you so much, Rochelle and Julia. So we'll use the remaining time we have to take your questions. So if you have a question that you'd like to ask, please type that into the Q&A box. So we've already got a few questions in, so we'll just jump right in. The first question we have, I'll direct this one to Rochelle. It says, do fully vaccinated people need to be tested for COVID-19 if they are exposed to someone with COVID-19?
Thanks, Megan. So the recommendation as it stands today is that fully vaccinated individuals do not have to be retested after an exposure to somebody with COVID-19.
Great, thank you. Julia, can a person initially test negative and then later test positive for COVID-19? Yeah, so that's a really great question. So it depends on the test that the person gets. So certain tests are more reliable than others. So it could be a false negative even when somebody may have an actual positive for COVID-19, but also sometimes earlier on, after contracting it, one also may have a false negative. So, a negative test does not mean you do not have COVID necessarily. So that is something to still be very conscious of. Great, thank you. Next question seems like a common question, and that is, can someone be reinfected with COVID-19 if they've already had it?
I'll go ahead and take that one. And there have been reports of people who have had a previous COVID-19 infection being reinfected with the virus. I will say that there is still a lot that is unknown about the immune response in terms of duration of immunity. And other human coronaviruses have also been correlated with reinfections as well. I think it's, as far as duration of immunity, that's something that we will probably find out in due time as data evolves and as more people are, vaccinated or exposed to the virus.
Great, thanks, Rochelle. Julia, when is a person considered infectious? Yeah, that's a great question. So The period of infectiousness still isn't really understood for sure, but people who have mild to moderate COVID-19 can shed the virus for up to 10 days after their symptom onset. So it's also possible that those with severe COVID-19 may be able to shed the virus for an even longer period, like up to 20 days. And the incubation period for COVID-19 is known to have ranges between 2 and 14 days from what is currently understood. Wonderful, thank you. Rochelle, is there any evidence out there that the COVID-19 vaccines will need to be taken annually, similar to the flu vaccine?
No, I think that's something, it's a great question, and I think that's something that we will need to stay tuned for. It is possible, but understanding that COVID-19 standalone as a virus has also had other variants, I think that there should be something that is more mindful of maybe a comprehensive approach to protecting folks against coronaviruses. But that would be something that we would potentially see in the guidelines in the future as data sets evolve.
Great, thanks. We've got a couple of questions about the Johnson & Johnson vaccine, so I'll direct these to Julia. So the first one says, since Johnson & Johnson's vaccine efficacy is much lower comparatively, do you think there will be a booster for it? Yeah, so that's a really good question. So it's hard to compare. It's not really like comparing apples to apples. So even though the data is showing, like when you look at them head to head, that the efficacy is lower, there were a lot of different factors involved. The data was collected at different times. There were different variants out there, and you really just can't compare it head to head. So I wouldn't actually say it's necessarily less efficacious than the other vaccines. So right now the data is kind of pointing to if we need boosters, we're going to probably need them for all of the mRNA vaccines, not just like one over another, but that may change as we learn more. Thanks, Julia. And a follow-up to that, if you have had COVID-19, is it suggested to not get the J&J vaccine? Yeah, so I actually haven't heard that before. I'm interested where that person had heard that, because that isn't familiar to me. But right now, if you've had COVID-19, it's still recommended to get whatever vaccine is available, as long as you're not still symptomatic and you're outside of that that window that they have based on the site where you get the vaccine. Great, thanks, Julia. Let's see, we've got a couple of questions related to children. So the first one says, if a child is exposed to someone with COVID, does the likelihood of them transmitting it to other people follow a time course similar to adults? For example, most likely to shed virus for the first 10 days after exposure and then unlikely to shed after 14 days?
So I would say that, if a child is exposed to someone with COVID-19, really kind of the recommendations are probably really mimicking that of an adult who is exposed to COVID-19 in terms of their ability to not only, contract, but, quarantining for 14 days, as well as, limiting that exposure to other folks outside of their household. If they do become infected and be shedding that virus and being most infected within those 2 days, first 2 days of symptom onset, and then they will shed the virus throughout the duration of illness, it is potential for both children and adults to continue to shed that virus for greater than 14 days after they either last had symptoms or if they had been asymptomatic. But I would say that more data is needed in terms of children, their capacity to contract COVID-19, as well as what does that look like from a transmission perspective as well.
Thanks, Rochelle. Another question we have here, and it asks why other countries, they give an example of Canada, why there's 3 months in between doses?
I can answer that one. So my grandparents are actually Canadian, so I've been very interested in this. So the reason why Canada is spending 3 months in between doses, it's not necessarily backed by scientific evidence. So I think it's really up to the country and their distribution plan, and it could be that they don't have enough vaccine supply and they're trying to kind of ration it in a sense, but there is no science that really supports that yet, clearly.
Got it. Thank you. Julia, is there any specific evidence that poorly controlled type 2 diabetes with frequent hyperglycemia increases COVID complications?
Yeah, so there's actually evidence that those actually with both type 1 and type 2 diabetes who have higher baseline A1Cs, like I think looking at the study, it depends, but I've seen over 8 and over 9 seem to be the studies that have this data. They do have worse COVID-19 outcomes. I don't have data on which type of complications they get necessarily, but they get more severe cases and end up with hospitalization. But I think the long-term effects, like the cardiovascular events that may happen, not immediately in association with COVID, that may happen longer term, we still are understanding that.
Yeah, and I can even just add another point there in terms of what is seen in the setting of type 2 diabetes. You see that metabolic inflammation, and that can also exaggerate that cytokine release, and that has also alluded to more detrimental outcomes seen in patients who have comorbid diabetes.
Great, thank you both. We are out of questions right now, so I think we'll go ahead and move to wrapping up today's webinar. So Rochelle and Julia, thank you so much for presenting today, providing this very important information and answering our questions. And thank you all out there for attending today's webinar. This webinar was recorded and it will be posted on our website, diabeteseducator.org, at the link that you see there on your screen. You can click right on that. The recording will only be available for 90 days, so make sure you check that out. And save these dates for the upcoming webinars in our series. The next webinar will be on June 9th on guideline updates and implications to patient care. So you can find more information and the links to register at that link on your screen. So thank you all. This concludes today's presentation.